Is it gonna? Okay, good, perfect. Okay, so listen, I have a few things, okay, to cover. The first one here, this one is chest pain. Most of what we're going to talk about today is going to be cardiology heavy. A lot of cardiology, how to deal with coronary artery disease, acute coronary syndromes, and like cardiac chest pain, and most importantly, how to deal with CHF, congestive heart failure. I'll keep that until the end. And if we have time, I'll go over right heart caths, and I have a whole one about it. Okay, so chest pain. Okay, this is similar to the previous ones we talked about when we talked about, you know, if the nurse pages you and tells you, hey, the patient is having chest pain, what do you do? Okay, so if you get this page and the patient is having chest pain, or if the patient shows up to the emergency department having chest pain, what do you actually do? So when you're dealing with this, the first thing that comes to your mind has to be, you know, is this chest pain cardiac, or is this chest pain non-cardiac? Okay, the most common non-cardiac chest pain is GI, is esophageal pain, reflux or spasms or food impaction, whatever. But it's more important to rule out that there's something cardiac going on. So, you know, in your mind, your differential diagnosis should be wide for chest pain. So it could be MI, could be PE, pneumothorax. I always say, never forget that sepsis. Any change in the clinical status of the patient is sepsis until you prove otherwise. So in your mind, keep sepsis in your mind, regardless. Patient complains of, you know, finger pain, sepsis, headache, sepsis. Just keep it in your mind so you don't miss it. Okay. So the first thing you're gonna do, you're gonna assess the patient, right? You're gonna go see the patient, and then you're gonna assess the vital signs, and you're gonna, you know, take a brief history and then assess their vital signs, make sure they're stable. Or not, regardless of what it is. And then the things that you want to do are usually an EKG. Very important, because this is going to be the defining feature between something cardiac and non-cardiac. And then you can also check at troponins. The idea about checking troponins here is to see if there is cardiac damage. Troponins, we're going to talk about it, does not completely rule out cardiac pain. So if somebody has negative troponins, does not necessarily mean that they don't have cardiac chest pain, okay? But it's important to do, because if they do have positive troponins, it's very specific, right? And then finally, you know, you do a chest x-ray. That's what I would do. I would do all these three. You can check other labs, but these three are really the most important ones. If you determine that the patient has cardiac chest pain, whether from your EKG, from the description of the chest pain, or from the troponins, then you have to go into kind of deeper into the realm of cardiac chest pain and figure out, is the patient having an acute coronary syndrome or not? And if yes or not, then you have to manage it as cardiac chest pain, whether it's ACS or not. Now, if you ruled out cardiac chest pain, then you can consider this as a GI chest pain. And then what you can do is it's either GI or it's either lung. So you have to rule out there is like a pneumonia, because sometimes pleuritic chest pain can be pneumonia, pneumo, or even a PE. And then finally, if it's really nothing, it's just GI chest pain, then you can try with few things. You can either try with antacids. You will see something that will tell you to give Malox, or like there's like a magic cocktail, whatever they give it, and sometimes it relieves the chest pain. PPI may or may not work. And then if it's like costochondritis or something musculoskeletal, especially if it's reproducible, when you press on the patient's chest, you think of something more musculoskeletal, then you can do Tylenol or NSAIDs or something like that, okay? These are the basic things you have to do for chest pain, okay? This is very simple, all right? Give me one sec.